my supervisor to say, my clinic is full of people I'm very concerned about. They say they've had an infection. I can't find anything on tests, but they seem very fatigued. They can't do anything. They seem very disabled. And I really feel we ought to be able to do something, but I've got nothing to offer. Often the call from medicine is, I'm desperate, I've got nothing to offer. Maybe you could do something, but okay, that's okay. Let's work with that. So the first thing I did was to try and, first thing I did actually, before we even get that, is I went and sat in the clinic. And I really think there's no substitution to just immersing yourself in a clinical problem. I sat in his clinic, then I started seeing some of the patients in my own clinic, and I did lots of informal, open-ended interviewing, read about the subject, just immersed myself in it. And one of the things that became clear is we didn't have a good definition of this problem. So it's very hard to do research on something if you can't define what it is you're researching. So with colleagues, we set up a meeting where we agreed across disciplines some definition of what this problem was, and a very simple definition, rather like the definition of chronic pain. So fatigue was their main problem, had been there at least 6 months. They had lots of other symptoms, and the physicians couldn't find any cause. So we had a group of these people coming through the clinic. What's the next thing we want to do? Well, I had some impressions from listening to them, and we then went on to do more formal description in a qualitative study. And qualitative studies have their limitations, but they're great at this stage to get a grip on the phenomenon. So these in-depth interviews that were then qualitatively analyzed found that these people, even though their physicians couldn't find any bodily abnormality, many of them, or most of them, believed that they had a physical illness that hasn't been found. They thought that if they did things and the symptoms got worse, that indicated that physical illness getting worse, and that was dangerous. And as an understandable result, they limited activity and exercise. So this seemed to be the picture that was emerging. So that's interesting, I thought, but that's a small sample. So the next thing to do, having got a qualitative handle, is to get quantitative, get into numbers. And so we did I did a survey got the details of patients who had been seen in this clinic with this diagnosis, and sent them a questionnaire. We got 144 questionnaires completed, and amongst the questions was what they think the cause of the illness is, how do you cope with the illness? And we found that not all, but a large proportion of them felt that they had a medical condition, and that many of them avoided things, including exercise, that they thought were making it worse, like symptoms. Interestingly, on the social bit of the biopsychosocial, we found that if they were members of a patient organization, they seemed to have a worse outcome. Beware, correlation doesn't mean cause, but that was an interesting association, because it could be that being in a patient organization reinforces these thoughts about the illness. So we've done some description. What are we going to do next? Well, is this specific? So this was a study done with colleagues comparing the views about symptoms in a group of chronic fatigue patients with depression, some people who were well, and some people who had multiple sclerosis. And the idea that symptoms were evidence of a physical illness was very common in the chronic fatigue group, much more common in a depressed group, or indeed the healthy group, and were at a similar level to those who had multiple sclerosis, MS. So it seems that we've got some idea that there's some kind of psychological and behavioral pattern here that's very common in this group. How could this possibly contribute to their illness? And I hope you're familiar with this, but this is a kind of all-purpose biopsychosocial model. So this reminds us to look at the biological, the psychological, and the social. And really importantly, it encourages us to think is, why did the person get ill? What predisposed them? What may have triggered the illness, precipitated it? And really interesting, why have they not got better? What's keeping the illness going? Because mostly we get better from illnesses. If it were an infection, for example, most of us get infections and get better. So you could start to sketch some things in. Some of these are just hypothetical. Maybe there's some genetic vulnerability. Maybe it's triggered by an infection or other illnesses in the biological line. And there's something physiological going on, we assume. We now know a bit more than we did then about changes in brain functioning and sensitization to symptoms and so on. Psychologically, where we were really quite interested, because we're adding something here, we presume some kind of vulnerability. The patients often reported some stress at onset. But importantly, as you saw, we found that they tend to assume their symptoms reflect a disease, they're fearful of making it worse, and they avoid. And socially, we're sketching this in, we don't really know, the stresses are probably important. And we were seeing some evidence that learning a story of the illness, a narrative from patient organizations, seemed to reinforce the psychological. And also we saw people who'd been ill who clearly now were stuck in not having work and dependent on state benefits and so on. But the bit we're really interested in is this bit. So if you're going to understand a condition, you need to know the whole thing. If you want to treat it, it's only really the perpetuating that's important. It doesn't really matter what happened down here. What matters is, what can we do about any of this? So can we do something? Can we see if we can change how the patients think about their symptoms, how fearful they are of them, and if they get more active again, because these people are very disabled by definition, could this help? So this is just a kind of static model of the columns, but of course, as Engels said, these levels interact. So we developed a number of models. This is one of them that we published, that had this idea that these variables interact in vicious circles. So it isn't just you have the thinking, you have the behavior, and you have the bodily state. The things interact. So this is a slightly complicated one, but it puts together believing a physical illness, fearing that symptoms mean harm, therefore avoiding activity. And in this case, this was to explain the oscillation, get pressure builds up to do stuff, social pressure or pressure yourself to achieve stuff. You do stuff, you feel terrible, you then go back to being inactive again, and you're stuck in a vicious circle. So a lot of these models have circles where the thinking affects the behavior affects the physical state, and so on. So we can now start to sketch that these factors might interact to perpetuate the illness. So here's the acid test, the experiment. So I did what by modern standards is an embarrassingly small randomized trial. That was 30 patients a group. And I and some psychologist colleagues treated them quite intensively with the form of CBT, which encouraged them to think about whether their symptoms really were dangerous, and to try out very gradual increases in activity, reducing avoidance. That wasn't the only things going on in the therapy sessions, but that was the core we were trying to do. And we found quite dramatic improvements in their functioning compared to just people having ordinary follow-up. So this is what we call an efficacy trial or a proof of concept trial. It was done in ideal conditions. You can't go straight to the real world from this kind of thing, but it gave us the idea that these associations of beliefs and behaviors might be more than associations. They might actually be perpetuating, because if we could change them, it seemed to change the illness. So some years later, I had an opportunity with colleagues to do what we'd call an effectiveness trial. So this is a big, expensive trial. This was 600 patients in multiple centers to see whether this kind of approach would work in the real world. And this was published as the PACE trial, published in the Lancet. And we found that interventions, so there's 4 lines on each of these, I'll explain them, but the interventions that got people to rethink what their symptoms might mean and to become more active, improve their functioning more than just usual medical care or staying within your limits, not worrying yourself with symptoms. And it improved not just the functioning, but also the fatigue. So here we see this is 0 to 12 months on the bottom. Whoops, sorry. And we see the active therapies that focused on behavior or focused on thinking, but both were essentially similar, brought down their fatigue much more than usual care or being told to to live within your limits. And similarly, the physical function had the same pattern. The function improved in those who had the more active treatments and more than it did in those who had usual care. So there, it looks like we now have enough evidence in this journey from starting in that clinic to have a useful treatment that people might be able to use. But of course, research doesn't stop there. You really need other people to confirm that this is a finding. There's a big problem in psychology research, as you know, of findings not being replicated. So this particular finding has been replicated in multiple countries and multiple trials. And indeed, I think people are improving on the treatment. It's quicker now than we did and maybe more effective. And people have started, been going for some years now, actually doing it in clinics. And latterly, the same approaches seem to be, the trials are coming out. It seems to be helpful for long COVID. Some of you may know that along the way, this wasn't a straightforward journey because some patient groups were very unhappy about this, but that's a story for another day. So just to recap the research journey, you need to be clear what it is you're studying, really get into it like getting into a warm bath, completely surround yourself with it. Do some description, create some kind of tentative model, test predictions from that model, often in a trial, but could be an experiment, and hopefully other people will replicate it and then start to implement it in the real world if it looks useful. It's not always you'll have the chance to do such a long journey as this. This is in total probably 20 years work. But, you know, if you start young, you can. But you don't have to do the whole journey. It was just an unusual opportunity to be able to make the whole journey. So just to summarize then, psychosomatic medicine doesn't ignore biomedicine or the biology of disease. It adds to it psychological and social factors and looks for interactions. Modern clinical services exist. Psychosomatic medicine, CL psychiatry, clinical and health psychology. Research really focuses on addressing the role of psychological and social variables in physical illness and its treatment, but it's not restricted to that. The full range of textbook research methods can be applied. I haven't talked about laboratory studies here, but people like Omer van der Berg have done important work there. And probably for many of us, the ultimate aim isn't just to produce a paper, but it's to actually improve better treatment for patients. So I just want to finish by mentioning EAPM. Hopefully you know about it, and hopefully you know that this is a great home for people interested in this area of research and practice. And you also know that Fia Mehta is president of our meeting, which is going to be in Florence in just a few months' time, and I do hope you're going to come. Thank you.
Thank you very much, Michael. Thank you. Yes, maybe we can open for around 10 minutes maximum to questions, so we have the opportunity to share. Also some doubts on ongoing studies. Sorry. So if you have questions, you can simply open the microphone, or if you prefer, you can write the question in the chat. It's up to you. If someone needs a kind of translation, I can do it. In the meantime, while people think about possible questions, I was considering this table that you proposed, the table with bio, psycho, social factors, predisposing, precipitating, and perpetuating. And I was wondering whether you may, I don't know, you suggest, especially in the phase in which you are building up your protocol, to try to focus on a table like this one in order to have a clearer ideas in mind, and so formulate an hypothesis. So the question is, do you think it's a tool in a way to be used to have a proper research protocol or not?
I think it's a useful way to just help us frame our thinking. It's very useful clinically, I think. I think it may be useful in research protocols, but I think the risk is it leads people to think they need to do more than you can in a single study. So it's really important to be very specific and really just look at a small number of variables and one or a small number of relationships, and not try and do the whole thing. And I think one of the risks with people, particularly early in their career, who are really keen to do something useful, is they do too much. And it's better to do something very specific very well than to do something very complicated very badly. So I think it's a useful memoir, but I think we need to move on from that to look at a more specific plan that looks at specific limited number of variables.
Thank you. In the chat, Dennis Linder wrote, thank you for the wonderful talk. Do you consider life course research a domain of psychosomatic medicine, in as much as it concerns the interaction of chronic, between brackets, disease, life events, life-changing decisions, and so on?
Yeah, life course research is very interesting. One of the first papers I wrote was on life course, and Adolf Meyer, who I mentioned, who I got to know because the American Psychiatric Association kindly gave me an award with his name on, so I had to read all about him. And he did life charts, was actually a big thing of his. He felt that you ought to trace the person's life and put on there the things that happened to them and so on, and that was a good way to understand them. The challenge, I think, is moving from a life course to a quantitative description, but I don't think that's impossible. I think it's a good clinical tool. It's a nice descriptive tool, but the challenge will be moving that to a quantitative conclusion. But I think it's a great thing to do. I wouldn't discourage it.
And I have another question still. Okay, Dennis says thank you. So while people maybe think about other questions, I was thinking that sometimes what we read or sometimes what we write is to try to not simply conceive bio, psycho, social as element to be added, but to try to conceive all of them together in order to catch the interplay as you suggested. So do you have, how can I say, nice tips to do this? Because apparently it's not an easy job to do such a conceptualization and frame.
So again, forgive me, I'm going to kind of say the same thing for you, Meta. I think it's really good to have a model or a diagram or an idea that looks at the whole picture, that's biopsychosocial. But probably when it comes to a research study, you need to look at a little bit of the picture rather than the whole picture, because it just ends up too vague otherwise. But maybe have the idea of the whole picture, maybe draw the diagram and test certain bits of the diagram. So you see in the work I described, which was, it wasn't any great wisdom. It was a young researcher modeling through. But you could start to say, well, are these things there? Are they specific? Do they relate to other things? Is it causal? Can we change them? But if you try to look at it all together, the biopsychosocial, what happens when the brain and their beliefs, and then how does that reflect their social circumstance, it would just be overwhelming. So absolutely to have the picture and then choose a bit of the picture.
Thank you. So apparently people are joining even though they miss the presentation. But of course, people are probably working, and so they simply, try to.
I can do it again quickly in 10 seconds.
Okay. Is there any other question or doubt or reflection, or someone who wants to share an idea and receive a kind of quick feedback on research? Okay, the audience is quiet.
Well, one of the things that I would say, I don't know what stages people are at, but so I did research pretty much my whole career, and I'm now 72, and you don't know, you muddle through, and I can tell a story. I've got a couple of topics where I've been lucky really to be able to follow them through over a number of years. Often, and I've done lots of just single studies. I went into a topic, I did a study or two, and I left the topic again. But this one, depression in cancer, just by kind of muddling through and taking opportunities, I managed to go from description to implementation. And that's a very satisfying journey. But it makes it look impressive when you look back and say, oh my God, he worked all the way through. But I was just trying to do my best at each stage. But I do think if people are really interested in a topic, it's worth trying to see if you can work it through and go through the different stages, even if there'll be setbacks and there'll be gaps in funding and, you might lose interest. But it's quite good to think of it as a journey. And to start from the beginning and just try and see how far you can get. But it does mean you have to, that chronic fatigue story, I put it down, I picked it up again. Once you get your teeth into something, you kind of never let go of it really. So opportunities will come up later on. So I would just encourage people to just choose a topic or something and just try and just stay with it and just keep going with it and talk to people. There'll be gaps, there'll be setbacks, but just kind of keep going.
Okay. Tomorrow we'll try to keep in mind this encouragement when we'll collect data, or maybe if you are in front of your patient too.
It's a secret of life here, Meta. It's keeping going. That's
not only in the working life. Okay, so thank you again, Michael. It was really a pleasure to have you as a guest of our short webinar series, but we hope that it will become a long series over the time. And just to remind a little bit that in case the attendees are interested in the activities of the Gruppo di Ricerca in Psicosomatica, we have a web page, grponline.org, and there you can have the opportunity to click on the link to receive our newsletter, so you can know which are our activities. We run sometimes webinars, usually at least once per year, and every other year we also organize a national conference. So next one will be in 2027, and it will be in Rome. And maybe we can meet around during the EAPM conference in Florence in June. So of course, everyone is welcome. And in that occasion, we will have also a pre-conference course specifically devoted to young early career people in psychosomatic medicine, independently from the age, let's say, and the previous experience. So I see that in the chat, people also thank you for being with us. And I hope that we have other occasion to exchange ideas and to listen to each other. So many thanks again, and have a nice afternoon and evening. Thanks a lot.
Thank you very much for listening. Thank you, and thank you for having me talk. Bye-bye.
Bye-bye.